My name is David Wise. I'm a maxillofacial surgeon here at CMC. Been here for about 29 years. And I assume that since you're here today, we're probably seeing you for your sleep apnea condition and inability to tolerate CPAP, BiPAP, APAP, whatever. As you may be aware, that's a condition that can be life-threatening and can cause a lot of serious problems for you, for quality of life, as well as other serious health issues. I'm basically helping patients now with their sleep apnea condition because I actually have sleep apnea myself, and I've gone through this process and actually have had the Inspire device implanted into me. There are other options here that we can offer patients with other surgical modalities or with devices that you put in your mouth that hold your airway open, but most of the time we're focusing mainly on the Inspire procedure because it's got such a great alternative for patients with a sleep apnea condition. Gone through now somewhere a little bit less shy of 250 cases here at CMC in the last 2 years, and we're almost to 150 even just this year. At this point in time, I'm the top implanter for West Virginia and second in the region, and I don't say that to be bragging at all, but that we do quite a few of these and want to make this patient experience as best for the patient, give them the best quality of care that we do here for CMC patients, and try to hopefully eliminate their sleep apnea condition, if not significantly improve it. Sleep apnea affects a lot of people. There's over 20 million people in the United States that are affected by this condition. It's actually as common as asthma. And it's a condition that's fairly undiagnosed. It's a condition that unless you have somebody tell you have sleep apnea and you've got a sleep study that you've had done to kind of document it, you may just feel like you're run down and tired and don't have energy and may even have some dangerous conditions like where you fall asleep at the wheel or at work or those kind of things. And it really can have a deleterious effect for patients and can shorten your lifespan. Sleep apnea can occur either in a central form where your brain doesn't tell your lungs to expand and to breathe, or it can be an obstructive form where somewhere in your anatomy above your windpipe or your trachea that blocks the airway. That can be due to large tonsils or a deviated septum or long soft palate or those types of things, large tongue or those types of things. It's basically diagnosed with a sleep study. That sleep study can be done at home or it can be done in an in-lab or hospital setting. And the home studies are fairly unobtrusive, where you put a device on your finger and something around your chest, or they have different types, but you basically wear this thing at night in your own comfort of your own home, and then you download that data to your smartphone or bring back the box or the device that the pulmonologist sent home with you. And then that gives you something that gives you feedback by the pulmonologist reading that study. If you have it done in the in-lab, they do a lot more testing and look at brain waves and movements and those types of things. But your basic home study looks at your oxygenation, it looks at breathing, heart rate, and those types of things. And basically, sleep apnea is diagnosed when the condition has a number over 5, and then it's divided into mild, moderate, or severe as far as severity. There are some terminology that's used that sometimes patients don't understand. For instance, AHI stands for apnea-hypopnea index, and apneas are where you stop breathing by more than 10 seconds. Hypopneas are where your oxygenation level drops by more than 4%. And the number of apneas plus the hypopneas divided by the sleep time gives you a number per hour. And that number per hour is where I mentioned if this number is 5 or over, you have sleep apnea. And less than 15, you have mild sleep apnea. 15 to 30, you have moderate, and then over 30, you have severe sleep apnea. And they look at also the time of your apneas and your lowest oxygenation rates and things like that. We now have Inspire that is actually a very unique type of operation, and I'll talk about that shortly, but it's a procedure that's an outpatient procedure, and typically, since I've gone through it myself, I know exactly what patients go through, and I think it's an excellent way to go. Essentially, a device is implanted into the chest. It looks like this, and it's similar to a pacemaker for the heart, but it's more kind of a pacemaker for your airway. And the way this works is, and it's put right underneath the skin tissue, above the pectoralis muscle, and it typically has two what we call leads or wires, if you will. There's a lead that we implant in between the ribs that determines when a person is breathing, and that sends this information to the IPG or the impulse generator. And then there's another lead that goes from the device that's usually implanted below the clavicle, and usually on the right side of the chest, and that lead comes up into the neck and goes to the hypoglossal nerve. The hypoglossal nerve is the 12th cranial nerve, and so the name of this device is Inspire, but technically it's a upper airway hypoglossal nerve stimulation procedure. And what this does is rhythmically sends an impulse to your tongue to stiffen the tongue and cause the tongue to project forward. And when it does that, it opens up the airway. And it's essentially opening up your airway as you're breathing and proactively prevents the obstruction before it occurs. Again, if a person has other obstructions in their airway, those can be treated surgically, but the bulk of the patients usually have a problem with their palate, base of tongue, and the lower airway with the obstruction. Basically, this again is an outpatient procedure. It takes me a little less than an hour on most patients to place the device surgically. Patients go home that same day. Typically, there's 2 incisions. I mentioned it's usually placed on the right side. Sometimes if patients already have pacemakers or defibrillators on the left, on the right side, we can put it on the left side. The nice thing about this is the battery life. The battery life is at least 10 to 12 years plus. It kind of is determined by the amount of energy that's inputted and how often it's used. We obviously want this used every night for the patients. When the device is first implanted, it's implanted and we make sure it works on the table, and then we turn it off. And then we allow about 30 days to have the device kind of integrate into your body and get stabilized, and then it's turned on at your pulmonologist appointment with the Inspire representative. And then essentially about 90 days out or 3 months out, you have another repeat sleep study to document its effectiveness. And essentially, like I said, we've got tons of data now as we've done almost 250 cases of the patients that I've done where we've actually cured a bulk of the patients or significantly improved their sleep apnea symptoms. Our goal is to get the AHI or apnea-hypopnea index to 15 or less. One of the other requirements, some of the other requirements for the Inspire is you have to have a sleep study that's been done within 2 years. That sleep study has to have that AHI of 15 or greater. The patient has to have a body mass index or that BMI of a certain number. There's different numbers used by different insurance companies. Medicare is about 35. Some of the other insurance companies such as United and the FDA has brought it all the way up to 40. It used to be that we were kind of limited on the AHI. If somebody had an AHI over 65, they couldn't have this done or wouldn't be indicated. But now the AHI has been raised up to 100. My AHI was actually 74, so I had pretty severe sleep apnea. I usually make a joke about this to my patients that if I actually had oxygen growing up, maybe I could have been a brain surgeon, but anyways. The other requirement that you have to have for Inspire is we have to do what's called a drug-induced sleep endoscopy. And what that is we have the patient come in, and normally, obviously, for any surgery, you have to have nothing to eat or drink after midnight or 8 hours before, and have an escort to drive you home. But we have you come in, we essentially get an IV started, hook you up to some monitors that fully monitor you, have supplemental oxygen on, and then anesthesia gives you some propofol to go off to sleep. And as you go off to sleep, when you start obstructing, I take a lighted endoscope and place it into the nose and then go back and look at your airway. And as long as your airway collapses more in a a flat type of collapse as opposed to what we call concentric or like a sphincter type collapse, you will be a candidate for the Inspire procedure. Unfortunately, about 1 out of 10 people, and sometimes a little bit more, don't qualify because of this type of collapse that they have in their airway. And if they do have that type of collapse, again, we have other procedures that we can do to help patients. But once we have all this information, and once your insurance company has approved your procedure, we take you to the operating room and then proceed to get the device implanted. And as I mentioned, you wait that 30 days and then start going up to become effective. And a lot of patients, even within the first week, notice a significant difference. I usually will see you about 2 weeks after the procedure just to make sure everything's going well and kind of check your incisions and that type of thing. A lot of times to improve scars, we'll mention things like digital massage and use of heat and products such as Mederma and that type of thing. And then the last, and that's the last appointment that you would see me with, but then you'll be seeing your pulmonologist and Inspire rep at about 30 days post-procedure, and then subsequently at whatever time frame they have you back in order to get the device adjusted, and then finally with the in-lab sleep study at about 3 months or 90 days from the procedure to do that final check and any adjustments that may need to be done. When you come and see me, we go over all of this information. We typically can do consents on the day that we see you. The hospital has consents that we do online that essentially doesn't obligate you as the patient. But again, these consents are good for 90 days, and they essentially allow the patient again to have a better understanding of what's all involved. In some cases, I may be not seeing the patient until the drug-induced sleep endoscopy procedure, as they might have a physician extender such as a PA or a nurse practitioner see the patient ahead of time for me. And then that was one of the purposes for this video, is to kind of give you as the patient a little bit of who I am and my experiences. And then we talk a little bit more about it, your drug-induced sleep endoscopy, which again is a fairly minimally invasive type of a process. With respect to anesthesia requirements, again, we mentioned not eating or drinking and having the escort. We may do this drug-induced sleep endoscopy in the main OR, but usually we do it in our outpatient surgery center. And it kind of depends upon the patient's medical condition and those types of things. Nowadays with patients sometimes on blood thinners, most of the time for that DICE procedure, we don't have to have you go off the blood thinners, but obviously you may be on the blood thinners for a particular reason. If we can get a note from your cardiologist that kind of says that it's going to be okay to take that inherent risk of going off that blood thinner, we try to get that when we actually do the procedure. For those patients that are diabetics, if they're on certain medications such as metformin, we need to go off of that 48 hours ahead of time. Other medications that are oral medicines such as Jardiance, we might have you go off 3 days before. And a lot of these new medications like Ozempic and Wegovy and some of these other medications, most of the time there's a inherent risk for anesthesia when you take those medicines because your stomach doesn't empty as quickly. And usually the anesthesiologist will want you off of those types of medications at least 7 days before the procedure. So we will talk to you a little bit more about that when we see you, or make counseling on what medications to take. Usually if you're on blood pressure medicines, if you take those with a small sip of water on the morning of the procedure, that usually helps keep the blood pressure down and that type of thing. So by giving you this information, hopefully this has provided some information that will allow you to make good decisions about your health care. And we feel, like I said, that Inspire has made great strides in taking care of patients and with this dangerous condition, and look forward to taking care of you.